Welcome to this high-yield deep dive. Listen, if you are tuning in right now, you are deep in the trenches.
Absolutely in the thick of it.
Yeah, you're prepping for the boards, probably gearing up for a massive hurdle like the FRCS in plastic surgery.
And we know exactly what that pressure feels like.
We really do. And you are looking for a highly focused, highly analytical revision session, which is exactly what we are delivering today.
Just stripping away the noise.
Right, drilling entirely into the core reconstructive logic that you absolutely must understand to pass. We are going straight into the material, but before we tackle that first clinical scenario, I need you to do two quick things for me.
Very quick.
First, press follow on the show right now so you do not miss any of these targeted revision sessions. And please rate the show if you learned something valuable today that, clarifies your understanding.
It really helps.
It does. Second, and this is critical for your comprehensive prep, you need to get a premium subscription.
Yeah, you don't want to skip that.
That premium feed is exactly where you are going to listen to our dedicated journal club and our intensive clinical cases, deep dives. Make sure you get that sorted.
Definitely.
So let's establish the clinical mission for today. We are breaking down vaginal agenesis.
A huge topic.
We're going to explore the pathophysiology walk through the surgical reconstruction algorithms and dissect the Cordera classification for acquired defects.
Focusing really heavily on the spatial logic and tissue mechanics of it all.
Exactly. So let's get straight to work. When we look at the epidemiology and the primary presentation of vaginal agenesis, how often are we actually seeing this, and what is the definitive primary cause that candidates must have ready?
So it's a relatively rare presentation, but one you will absolutely be tested on.
Right.
For your epidemiological baseline, you need to state that it affects between 1 in 4,000 and 1 in 10,000 female births.
1 in 4,000 to 10,000. Got it.
Yeah, and when the examiner asks for the single most common etiology, your immediate reflex has to be Mayer-Rokitansky-Kuster-Hauser syndrome.
Which we just call MRKH syndrome normally, right?
Exactly. MRKH syndrome.
MRKH is an incredibly dense, high-yield topic, and examiners love to probe your understanding of it because it requires you to sort of separate the anatomical deficit from the endocrine function.
Which is where a lot of people trip up.
Yeah. So if an examiner leans across the table and asks for the exact clinical definition of MRKH, what are the precise, non-negotiable components of a passing answer?
You really must structure this definition in two contrasting parts to prove you truly grasp the condition. The first part is the overt anatomical deficit.
Which is?
MRKH is defined by the congenital absence of the uterus and the vagina.
Right. No uterus, no vagina.
But if you stop there, you fail the question.
Because you're missing the other half.
Exactly. The second equally critical part of the definition is what remains intact. You must explicitly state that despite this profound anatomical absence, these patients possess a completely normal female genotype. They exhibit entirely normal secondary sexual characteristics, and most importantly for their physiological development, they have functionally normal ovaries.
That is the exact clinical nuance that separates an average candidate from a great one.
Because the ovaries are normal.
Right. These patients are going to experience typical hormonal cycles. That means they might still experience cyclic abdominal pain or breast tenderness during puberty.
Yes.
It's a vital clinical clue when you are evaluating a teenager who presents with primary amenorrhea but otherwise normal development. Now, if everything hormonally and genetically is completely typical, what is the specific embryological failure that causes the anatomy to just not form?
It all comes down to a very specific failure during early fetal development.
Which is?
The congenital absence results directly from the failure of paramesonephric duct development.
Paramesonephric duct.
In a viva setting, failure of paramesonephric duct development is the precise, undeniable embryological terminology the examiners are waiting to hear. If you understand that those ducts are supposed to fuse to form the uterus and the upper portion of the vagina, the entire anatomical deficit of MRKH makes perfect logical sense.
Let's follow that embryological logic a step further. If the paramesonephric duct fails to develop, we cannot just look at the pelvis in isolation.
No, definitely not.
Embryologically, those tissues are developing in close proximity to other vital systems. So what else is going wrong in these patients, and how does that dictate our initial workup?
That is exactly the mindset you need for the boards. You cannot view this defect in isolation, and you cannot safely take these patients to the operating theater without a broader anatomical survey.
Because of what else is nearby.
Right, because of that shared embryological timeline and proximity, exactly 30% of these patients will present with associated abnormalities of the upper urinary tract.
30%, that's huge.
It is. You need to be ready to list the 3 specific structural manifestations of this, which are renal agenesis, a pelvic kidney, or a horseshoe kidney. Because that 30% association is so incredibly high, it is absolutely mandatory to investigate the renal tract.
And what's the imaging of choice?
The definitive imaging modality you must suggest in your management plan is an ultrasound or an MRI.
That 30% figure is a massive red flag. It shifts your entire approach from a localized reconstructive problem to a systemic anatomical evaluation.
Exact.
Imagine the disaster of planning a complex pelvic reconstruction without realizing there is a pelvic kidney sitting right in your surgical field.
It would be catastrophic.
You absolutely must order that ultrasound or MRI. So moving from the imaging to the actual clinical encounter, how do these patients typically present to our clinics?
The vast majority of these patients will present during puberty, and the exact nature of their presenting symptom branches based on their specific internal anatomy.
Okay, break that down for us.
If there is no uterus present, which is the classic MRKH presentation we just outlined, the presenting symptom is simply primary amenorrhea.
Right. The patient isn't menstruating when expected.
Exactly. However, the presentation changes dramatically in cases of vaginal agenesis, where a normal functional uterus is actually present.
Because the blood has nowhere to go.
Precisely. In those specific cases, the patient may present with severe cyclic pain and hematocolpos, which is the painful accumulation of menstrual blood trapped behind the azadogenesis.
That is a critical branching point in your clinical reasoning. No uterus equals a relatively silent presentation of amenorrhea. A normal uterus equals acute painful hematocolpos.
Perfectly summarized.
And when you actually perform the physical examination on these patients, you aren't just noting the absence of a normal introitus. You have to actively hunt for a very specific anatomical landmark, right?
You do. You're looking for the vestigial vaginal dimple.
The dimple.
Yes, finding that tiny epithelialized depression is going to completely dictate our treatment algorithms.
But before we talk about how we treat, we need to talk about when. We have a diagnosis in a young teenager. When does treatment commence?
The timing is perhaps the most heavily tested principle in this entire topic. Treatment should be strictly deferred until adolescence.
Not childhood.
No, you do not intervene early in childhood.
Yeah.
This is a deliberate, calculated delay in the timeline of care, and you have to be able to defend it to the examiner.
You really have to put yourself in the patient's shoes here. You have a young teenager navigating puberty who suddenly discovers a profound anatomical difference. Telling a young girl she needs complex reconstructive management is an immense psychological burden.
It's massive.
So how do you clinically justify this deferment to adolescence when the examiner pushes you on it?
You justify it by focusing on the realities of surgical ethics and long-term reconstructive outcomes. Deferring until adolescence serves 2 non-negotiable functions.
First one being?
First, it allows for true informed consent from the patient herself. She has to be psychologically mature enough to understand what is happening to her body.
And the second?
Second, and this is the practical reality of the reconstruction, it ensures compliance. Any reconstructive algorithm we choose requires rigorous, painful postoperative dilatation. If the patient is not mature enough to comprehend and adhere to that relentless postoperative dilatation regimen, the reconstruction will stricture and it will fail.
Informed consent and absolute compliance with postoperative dilatation. You cannot expect a child to manage that burden.
Not at all.
Waiting until adolescence is the only way to secure a successful long-term outcome. Now, assuming the patient is at the right age, emotionally mature, and ready to proceed, what is the absolute first-line treatment and what is the anatomical prerequisite to even attempt it?
It is always fascinating that the universally accepted first-line treatment for a major structural defect is entirely non-operative.
Which is?
The gold standard is non-operative dilatation. But as you alluded to, there is a strict prerequisite.
The dimple.
Exactly. Effective dilatation requires the physical presence of that vestigial vaginal dimple we actively searched for during the clinical examination. Without that dimple providing a starting point, this first-line option is completely off the table.
That tiny anatomical landmark is your golden ticket for avoiding major surgery. Assuming the dimple is present, detail this non-operative technique for us. How does it actually work in practice?
The primary method you need to quote is the Frank technique, which was originally described back in 1938.
The Frank technique.
Yes, it is an exercise in applied tissue mechanics. It relies on a process of sequential expansion. The patient uses specific graduated tools, historically glass, but now typically plastic molds, to apply consistent pressure to the dimple.
Okay.
Over time, this mechanical creep expands the tissue to create a functional neovaginal depth.
So why is this still the first line after all these years?
The reason the Frank technique remains, the undisputed first-line treatment comes down to a simple risk-to-benefit analysis. The clinical success rates are remarkably high, and crucially, the surgical risks are practically zero.
The Frank technique from 1938, sequential expansion using plastic mold entirely dependent on the presence of that vestigial dimple. High success, incredibly low physical risk, but it does demand massive psychological resilience from the patient.
Absolutely.
Now let's say the dimple isn't there or the non-operative route has completely failed. We are now forced into the operating theater. What is the classic gold standard surgical approach for anagenesis?
When you cross into operative territory, the historical gold standard you must be able to describe in detail is the split-skin graft technique.
Known as
This approach was popularized by McIndoe.
the McIndoe technique.
Right. The surgical steps require precision. First, a surgically created new vaginal space is dissected between the bladder and the rectum. Then a split-skin graft is harvested and carefully draped over a specifically sized mold.
Okay.
This graft-covered mold is then inserted into the newly dissected space.
Let's pause on the mechanics of the McIndoe technique for a second. You have a split-skin graft sitting in a highly mobile, potentially contaminated field. How on earth do you ensure that graft actually takes to the surrounding pelvic sidewalls?
That is the critical surgical step candidates often gloss over. To secure the graft and ensure absolute apposition to the surrounding tissue, the labia minora, are meticulously oversewn.
Oversewn over the mold.
Exactly. This isn't just about closing the wound. Oversewing the labia minora acts as a powerful biological bolster. It locks the mold in place, preventing any shear forces that would otherwise disrupt the fragile split-skin graft during that crucial phase of neovascularization.
Oversewing the labia minora as a biological bolster. That is a brilliant way to conceptualize it for the exam. But the surgery itself is just the beginning. Talk to us about the post-operative reality for the patient undergoing the McIndoe technique. How long does that mold stay in, and what is the long-term protocol?
The post-operative regimen is incredibly demanding, which circles right back to why we defer treatment until adolescence.
Right.
That initial mold must be left in situ continuously for a full 6 months.
6 months.
It is a grueling process. Furthermore, even after that 6-month in situ period is complete, the patient is required to commit to regular ongoing dilatation. Essentially, yes, this is absolutely mandatory. If they stop, the newly grafted neovaginal space will inevitably undergo contracture and severe stenosis.
6 solid months with the mold in situ, followed by lifelong regular dilatation just to maintain the space. It really hammers home why patient compliance is the ultimate deciding factor.
It really is everything.
Okay. Now, if the split-skin graft McIndoe technique is contraindicated or fails, what are the alternative surgical techniques a candidate should have ready in their reconstructive ladder?
If you need to pivot to alternative techniques, you should inform the examiner that these are analogous to the methods we routinely use for acquired perineal defects.
Which are?
The first major option to list is the use of a pedicled segment of colon.
Okay, segment of colon.
And if you are looking at regional flaps, you should specifically name pudendal thigh flaps and the gracilis flap as your primary reliable regional options.
Segment of colon, pudendal thigh flaps, or the gracilis flap. That is a solid, defensible reconstructive ladder. And mentioning acquired perineal defects is the perfect pivot point for us.
Let's do it.
Let's shift our focus entirely away from congenital MRKH syndrome and look at acquired vaginal defects, whether from oncological resection or trauma. We need to dissect the Cordero classification.
Highly spatial system.
Right. We are going to walk through the spatial classification system step by step, matching the exact anatomical defect with its dictated reconstructive algorithm. Let's start with the partial defects, the type I category. What exactly are type IA defects, and what is the precise reconstructive choice?
The Cordero system is brilliant because it is highly spatial and logical. Let's build it from the ground up.
Okay, type IA.
Type IA refers strictly to partial defects that involve either the anterior or the lateral vaginal wall.
Anterior or lateral?
Yes. When you are faced with a type IA anterior or lateral defect, The reconstructive algorithm dictates the use of pedicled Singapore fasciocutaneous flaps.
Let's analyze why that flap is chosen. The pedicled Singapore flap is ideal here because it provides thin, pliable sensate tissue based on the pudendal vessels.
Exactly.
It perfectly mimics the thin lateral vaginal walls without adding unnecessary obstructive bulk. That is exactly why it is the definitive answer for type IA.
Perfect anatomical match.
Moving to the other side of the partial defect category, what defines a type IB defect?
Type IB completes the partial defect category by addressing the posterior aspect. Type IB involves partial defects specifically of the posterior vaginal wall.
Okay, posterior what?
Because of the anatomical location, you need more robust tissue between the vagina and the rectum. Therefore, these posterior type IB defects are reconstructed using pedicled rectus abdominis myocutaneous flaps.
That makes perfect anatomical sense. The posterior wall sits right on the rectum. You need the substantial muscle bulk of the rectus abdominis to separate those cavities and prevent fistula formation.
Exactly, you need that bulk.
So just to lock the type I partial defects in, type IA is anterior or lateral reconstructed with a thin Singapore flap. Type IB is posterior reconstructed with the bulky rectus abdominis myocutaneous flap.
Spot on.
Now let's scale up to the massive tissue losses. What defines a type IIA defect, and what is its reconstructive algorithm?
Type IIA shifts us from partial walls into true circumferential tissue loss. Specifically, type IIA covers circumferential defects that involve the upper two-thirds of the vagina.
Upper two-thirds circumferential.
Right. For this extensive level of defect, the primary reconstructive algorithm calls for a rolled rectus flap.
A rolled rectus.
Yes. And for the sake of completeness in your exam answer, you should also note a less common alternative for type IIA, which is the use of the sigmoid colon.
Type IIA is the upper two-thirds circumferential defect. The primary choice is the rolled rectus flap. Geometrically, you are taking a large, flat myocutaneous paddle and physically tubing it to recreate that upper cylinder.
That's the spatial logic of it.
And you keep the sigmoid colon in your back pocket as a secondary option. Finally, that leaves us with the most devastating category. What is a type IIB defect, and what is the reconstructive flap of choice?
Type IIB represents the most extensive defect in the entire classification system. It covers total circumferential defects of the entire vagina.
The whole thing?
Yes. For a total circumferential loss, the reconstructive tissue burden is absolutely massive. You cannot achieve this with a single flap. Therefore, these type IIB defects are reconstructed largely with bilateral gracilis flaps.
Type IIB is total circumferential loss demanding bilateral gracilis flaps. Yeah. You need the heavy-duty, robust muscle bellies from both sides just to line that massive pelvic cavity.
That's what it takes.
That maps out the entire Cordero classification system perfectly. From type IA anterior lateral with the delicate Singapore flap to type IB posterior with the rectus abdominis, then up to type IA upper two-thirds circumferential with the rolled rectus, and finally type IIB total circumferential, demanding the bilateral gracilis flaps.
As you prepare for your Viva, there's a final vital concept you need to mull over to really tie this all together.
What's that?
Consider how the distinct anatomical nuances of the Cordero classification perfectly dictate your choice regarding flap tissue bulk and pedicle reach.
It's not just a random list.
No, the algorithm isn't just a list to memorize. It scales mechanically. You progress from the relatively thin local Singapore flap for isolated lateral walls all the way up to the heavy-duty bilateral gracilis flaps required to fill a total circumferential void.
Right.
Understanding that spatial logic makes the classification intuitive rather than just rote memorization. Furthermore, remember the unifying theme of everything we have discussed in this session.
The compliance.
Exactly. Regardless of whether the defect is a congenital absence like MRKH syndrome or a massive acquired defect categorized by Cordero, the patient's compliance with postoperative care and rigorous dilatation ultimately dictates the final success of whichever complex surgical algorithm you choose to employ.
That is exactly the kind of high-level practical synthesis the examiners are looking for. You have to be able to connect the raw embryology to the reconstructive choice, and then connect your surgical execution straight back to the long-term reality of patient compliance.
It all ties together.
Thank you for joining us for this rigorous revision deep dive. We have stripped away the filler to give you exactly the surgical logic you need for the boards.
Good luck with the studying.
I want to directly ask you to leave a comment or a question below about today's material. Let us know how you are integrating the spatial logic of the Cordero classification into your daily revision notes. Keep pushing hard with your preparation. Trust the reconstructive ladder, and we will see you on the next one.